You have been told it is IBS, or stress, or something you are eating that disagrees with you. You have tried elimination diets, probiotics, digestive enzymes, and cutting out gluten for 3 weeks that changed nothing. The bloating comes back. The urgency comes back. The pain that arrives after eating and then mysteriously disappears comes back. What nobody has asked yet is whether your gut is the problem, or whether your immune system is using your gut to tell you something about a much larger process happening elsewhere in the body. The gut is the most immunologically active organ in the body. 70% of the immune system lives in and around the intestinal lining, which means when the immune system misfires, when it begins attacking its own tissue, the gut is one of the first places that attack becomes visible. And the symptoms it produces are indistinguishable, without the right investigation, from the functional gut conditions that millions of people are diagnosed with and managed around for years without a cause ever being identified. The gut symptom that most consistently signals autoimmune disease is not dramatic bleeding or obvious inflammation. It is chronic, unexplained diarrhea, loose, frequent, sometimes urgent stools that have been present for more than 4 weeks, that are not explained by infection, that do not resolve with dietary changes, and that may alternate with periods of relative normality before returning. Chronic diarrhea in an otherwise healthy adult is not a benign finding to be managed with loperamide and dietary fiber. It is a symptom with a differential diagnosis, and autoimmune and inflammatory conditions sit near the top of that list. The conditions most likely to be behind it are not rare. Inflammatory bowel disease, Crohn's disease and ulcerative colitis combined, affects approximately 3 million Americans and over 10 million people globally. Celiac disease affects roughly 1% of the population worldwide, with the majority undiagnosed. Microscopic colitis, an inflammatory bowel condition that produces a completely normal colonoscopy appearance to the naked eye, while causing significant inflammation visible only under a microscope, is diagnosed in over 100,000 Americans annually, and is almost certainly underdiagnosed in the remainder who are told their tests were normal. Each of these is autoimmune or immune-mediated. Each produces chronic diarrhea as its primary or dominant symptom, and each is missed, sometimes for years, because the symptom is attributed to IBS before an adequate investigation has been completed. Celiac disease deserves particular attention because it is simultaneously one of the most common autoimmune conditions and one of the most frequently delayed in diagnosis. The average time from symptom onset to diagnosis in the United States is 6 to 10 years. In celiac disease, the ingestion of gluten, the protein in wheat, barley, and rye, triggers an autoimmune response in which the immune system produces antibodies that attack the lining of the small intestine. Specifically, they destroy the villi, the finger-like projections that line the intestinal wall and are responsible for nutrient absorption. As the villi flatten and disappear, the intestine's absorptive capacity falls. Nutrients pass through rather than into the body. The diarrhea of celiac disease is frequently described as pale, greasy, and particularly foul-smelling, a result of fat malabsorption, since dietary fat cannot be absorbed without functional villi and passes into the stool. But this presentation is the textbook version. Many people with confirmed celiac disease have constipation rather than diarrhea, or alternating bowel habits, or no significant digestive symptoms at all, presenting instead with iron deficiency anemia that does not respond to supplementation, unexplained infertility, peripheral neuropathy, bone loss, or a skin condition called dermatitis herpetiformis, an intensely itchy, blistering rash on the elbows, knees, and buttocks that is pathognomonic for celiac disease and resolves completely with gluten removal. This is why celiac disease escapes detection so consistently. The gut symptom is the signal, but the signal is variable enough that it does not always point clearly to its own cause. Inflammatory bowel disease produces a different picture, one that more often involves visible signs alongside the diarrhea that, when combined, make the autoimmune origin more apparent. In ulcerative colitis, the immune system attacks the mucosal lining of the colon in a continuous, surface-level pattern that begins at the rectum and extends upward. The diarrhea is frequently bloody, blood and mucus in the stool, sometimes in significant quantities during a flare. The urgency is severe enough to wake the person at night. Cramping accompanies each episode. The systemic inflammatory burden produces fatigue, low-grade fever, and weight loss that accumulate over time. Crohn's disease is more unpredictable. It can affect any part of the gastrointestinal tract from the mouth to the anus, in a patchy, transmural pattern that penetrates through the full thickness of the bowel wall rather than just the surface. The diarrhea may not be bloody. It is accompanied by abdominal pain that can be severe enough to mimic appendicitis, a presentation that has sent many Crohn's patients to surgery before the diagnosis was made. Perianal disease, fistulas, skin tags, and abscesses around the anus, is present in approximately 30% of Crohn's patients and is one of the most specific external signs that the bowel inflammation is transmural and autoimmune in origin. Both conditions carry extra-intestinal manifestations that extend the autoimmune picture beyond the gut: joint pain that flares with bowel disease activity, eye inflammation, skin lesions called erythema nodosum and pyoderma gangrenosum, and primary sclerosing cholangitis, inflammation of the bile ducts, which is strongly associated with ulcerative colitis and carries its own significant morbidity. The gut symptom arrives first. These associations develop alongside or after it. Treating only the gut without investigating the systemic picture misses the full scope of what is happening. Microscopic colitis is the condition most likely to be diagnosed as IBS because every standard investigation comes back normal. The colonoscopy is normal. The biopsies taken from normal-looking tissue are what reveal the diagnosis. Under the microscope, there is either a thickened band of collagen beneath the surface epithelium, called collagenous colitis, or an abnormal accumulation of lymphocytes in the lining, called lymphocytic colitis. Both produce the same symptom: chronic, watery, non-bloody diarrhea, sometimes 10 to 15 bowel movements a day, in a person whose colonoscopy report reads entirely unremarkable. It predominantly affects women over 50, is strongly associated with the use of NSAIDs, proton pump inhibitors, and SSRIs, and is significantly underdiagnosed because the diagnosis requires biopsy of a colon that looks normal, and because many physicians do not take biopsies during a colonoscopy that appears unremarkable. The patient is told the colonoscopy was fine, and the IBS management continues. The biopsies that would have revealed the diagnosis were never taken. There is a pattern that, when present, should shift clinical suspicion away from functional gut disease and toward autoimmune investigation. Diarrhea that began without any identifiable trigger and is not fully resolved in more than 4 weeks. Diarrhea that is nocturnal, waking the person from sleep, because functional IBS almost never produces nocturnal symptoms. Weight loss alongside chronic diarrhea. Systemic symptoms: fatigue, joint pain, mouth ulcers, skin changes, occurring alongside or alternating with gut symptoms. A family history of autoimmune conditions including thyroid disease, rheumatoid arthritis, type 1 diabetes, or inflammatory bowel disease, all of which share genetic susceptibility pathways. Any one of these features in the context of chronic diarrhea warrants investigation beyond the standard IBS diagnosis. The investigation is not complex. A full blood count for anemia, CRP, and ESR for systemic inflammation, Celiac antibody screen including anti-TTG IgA and total IgA, fecal calprotectin, which distinguishes inflammatory from functional bowel disease with high sensitivity, and if indicated, colonoscopy, with biopsies from multiple sites regardless of macroscopic appearance. Fecal calprotectin is the single most useful first-line test for distinguishing inflammatory bowel disease from IBS in a symptomatic patient. A level above 200 micrograms per gram indicates significant intestinal inflammation and makes a functional diagnosis unlikely.